I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin. I'm joined by Volkmar Falk from Berlin. Volkmar, good to see you.
Good to see you too.
Enjoyed visiting with you. We could talk about rock bands.
We could.
But this is the Mitral Conclave. So tell me a little bit about, you gave a talk this morning about the evolution of access, and I really specifically want to focus on endovascular approach.
Yeah, so I think that we have seen a great evolution in terms of access to the mitral valve, coming from originally median stenotomy and large incisions towards videoscopic assisted and finally true endoscopic procedures. Right. And a majority of cases for degenerative mitral valve repair are done this way these days. But of course this is only an intermediate step towards what we now see is the percutaneous approach, and with all the new devices that have entered the market, this development is not going to stop.
I think you're exactly right. Do you tell me a little bit more about endoscopic? I mean, is that available to do all that's needed in a selected group of patients or a large group of patients with mitral regurg?
Well, first of all, I think for degenerative mitral valve insufficiency, surgery is still the gold standard. Okay. And with the excellent results that I also presented at this meeting, right, there's no doubt that this is also going to stay. But of course, we have to also meet the expectations that we do it with minimal trauma. And we have ways to do this now in a very efficient way, and also in a way that is reproducible by many. Needless to say, though, that there is still a volume-outcome relationship, and that we still have an argument to also specialize centers for complex mitral repairs, especially if done endoscopically.
Yeah, I mean, I think that's the important point. Do you see, what do you see as the progression then from endoscopic as we move into transcatheter therapies? I mean, where do you see this going?
Well, to have direct vision of the valve and all subvalvular structures obviously is an advantage.
Absolutely.
But with the occurrence of all the imaging technology that we have now available, it's almost the same view. Plus the advantage that the heart is actually beating, which as opposed to an endoscopic approach, provides you with the moving target, so to speak. And depending on what level the repair is being done, these methods will more or less be successful. We have seen devices now for chordal replacement, other devices for annuloplasty, maybe a combination of that. It will be very difficult to achieve exactly the same quality that we have with surgical repairs, but we will see history repeating, start in a high-risk population, slowly moving down to a lower risk population with advancements in technology.
It's going to take some time.
It will take some time, and I think as surgeons we will still have a lot to do for the next coming years.
I hope so. This brings me to the question of how do you, in Germany or worldwide, how do we train the surgeons now, and I mean moving forward? Because the interventional cardiologists, at least in this country, play an increasing role in this space.
Yes, and rightfully so. On the other hand, I don't see that surgeons should not engage in endovascular and percutaneous procedures. I mean, this to me seems natural with the background that we have. And I think it's really comes down to the centers and to the leadership in these centers, to good discussions with the cardiologists on site to set up programs where young people both from cardiology and cardiac surgery can evolve in this field. So I don't see this clear-cut separation between cardiology and cardiac surgery anymore. And I would hope that our young fellows will also be trained in percutaneous techniques to the benefits of our patients.
Yeah, no, I think it's absolutely critical. Are there patients in whom, and I can think of some, but are there patients in whom the endoscopic approach would not be appropriate?
I think those patients with severe annular mitral calcification are still a challenge because simply the endoscopic instruments cannot deal with this problem. Severe cases of endocarditis with annular abscess formation, difficult to handle. Then certain redo settings may be complicated. Patients with lung adhesions on the right side, this is a difficult problem for an endoscopic approach. But the majority of patients with degenerative MR have not been operated before and usually don't have too many other medical complications or comorbidities. So it's actually a good target population for an endoscopic approach.
Where do you think, and I think that's great, that's exactly what I was thinking, do you see transcatheter therapies going all the way to, I know it's already ongoing, but to replacement, transcatheter mitral valve replacement?
Yeah, that is an interesting question because unfortunately in the surgical community has failed over the past decades to provide good evidence from proper randomized controlled trials. To answer, for example, the question, is repair better than replacement?
Correct.
We all naturally agree that this is the case, but if you try to find in the literature any evidence for this, it's very difficult. Except for a few propensity-matched studies, no RCTs have ever been performed to address this question. Likewise with the question mechanical or biological valves. I mean, we assume that biological valves are the future and the solution for everything, but I'm not so 100% sure that that is the case either. But we have failed to produce the evidence in the past, and I'm afraid we won't in the near coming future.
Right.
Now, when it comes to the replacement, I think for functional MR, given the trials recently, it seems that it performs as well as repair, and it's probably easier to do than even a clipping procedure. And so I can see that that will play a major role in in functional MR.
And we're learning, I think we're learning tremendously about patient selection becomes really important. In other words, that there might be people who have such large LVs, volume and function is down and the right side's really down. So patient selection becomes critical, don't you think?
Yeah, absolutely. And that's, someone said it during the meeting that for functional MR, the heart failure specialist will be in the driver's seat when it comes to decision making. And the complexity of the situation has just been illustrated by the two mitral clip trials in the heart failure population. I should say I'm confused at a higher level now.
Very much so.
So I think it makes a lot of sense to increase the heart team, have a heart failure specialist on board, and really try to figure out what patient and what stage of the disease may actually benefit from any intervention.
Yep, no,
I mean,
that's the big question.
That is an art in itself.
Absolutely. Final question to you. It was said this morning that looking down the road 2030, 2035, wherever, that 3/4 of mitral valve procedures will be done transcatheter. Do you agree with that?
I would say for functional MR, definitely.
Yeah.
Maybe more. For degenerative, it depends pretty much on the outcomes. And I think it is absolutely unacceptable to consider a 2+ MR a procedural success. So that will, for DMR patients, not be accepted.
Absolutely.
And if there is a device or multiple devices that can provide equal outcomes as we have with surgery today, then it may be even more than that. But this is a long road to travel, and we will see.
And you know, you said earlier that we want to do what's in the patient's best interest. So the patient may want to have, sure, I'd rather not have surgery, I'll just have this, but that may not be in their best interest short term.
Yeah, and that to keep that balance means that also the cardiologists have to be very careful in how they inform the patients.
Correct.
And they really have to balance the short-term benefits of a percutaneous approach against the long-term outcomes by any surgical procedure that may have a little bit more cumbersome perioperative course.
Excellent. Thank you very much.
Thank you very much.
I always learn from you. Thanks very much.
Likewise. Thank you.
Thank you for joining us.